My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
So, as Brian just mentioned, the IAS, the science conference this year, happened in Paris. I sadly did not get to go, but I'm going to tell you a little bit about what I read as sort of the most interesting projects that got presented there. And then this slide has a link to the IAS website, which is a little bit more difficult to navigate. So the most of the studies that I'm going to tell you about are on this YouTube link. This was the session that was the update from clinical trials, which is going to include a sub-analysis that was presented from IPRGAE, something about injectable cabotegravir, a phase 2 trial, a little bit more about topical PrEP and the vaginal microbiome, specifically about the dapivirine ring, and then, just because Brian always tells me that you all like to hear about what's coming down the pipeline, a little bit about what's coming in the future around PrEP. There were few other talks that I was interested in, but unfortunately I couldn't they disappeared. There was one on adherence that wasn't available on the website or as slides, looking at how to measure adherence in clinical practice, and then a lot about uptake and interest in high-risk groups all around the world that you can take a look at if you are interested. But I thought the IPRGAE stuff was so interesting that I really wanted to take time to explore this. So for those of you who don't remember, IPRGAE was a study that was conducted in France and Canada that was looking at intermittent dosing of Truvada taken as PrEP. As you all know, what we have here as approved in the United States is the combination pill of tenofovir disoproxil fumarate plus emtricitabine as Truvada that is recommended for daily use. IPRGAE was a randomized study looking at this intermittent dosing strategy, and people were given a prescription and recommended to take 2 Truvada tablets 2 to 24 hours before they had sex, 1 tablet 24 hours later, 1 tablet 24 hours after that. If there was another sexual episode, they were instructed to continue taking it effectively daily until 2 days past their last sexual exposure. These are the results that were published in the New England Journal of Medicine a couple of years ago, and what you can see on the slide is that there was a clear benefit of Truvada taken as intermittent PrEP compared to placebo. There was a median follow-up of 9.5 months with 16 subjects infected, almost all of them in the placebo arm, for a relative risk reduction of 96%. In the open label extension, this was almost as high as 100%, I think it was 97% protective in the open label extension. But one of the criticisms about this in terms of trying to interpret the effectiveness of a intermittent strategy was the fact that in the overall IPRGAE population, there was a lot of sex that happened. So the population had a median number of sex acts of 10 per month and took about 15 pills per month on average. So the question really was, were these folks just having so much sex that this was effectively just daily PrEP? And the question remained, is this intermittent strategy where people take 2 pills before sex, 1 pill after that, and 1 pill a day after that, is that as effective as daily PrEP? And so is on-demand PrEP effective for people who really have infrequent sexual exposures where we might want to reduce both the cost and the drug exposure? And so this study that was presented at IAS was titled On-Demand PrEP Among Men Who Have Sex with Men with Infrequent Sexual Intercourse, a subset of IPRGAE. And the way they did this analysis was they looked at people who were adherent to the study regimen. So as part of their face-to-face interviews, which occurred at baseline and every 2 months, they asked participants, again, face-to-face, since the last visit, did you use the trial treatment systematically during sex, often during sex, from time to time during sex, or not at all? And these are their words, not mine. And so what they're presuming is, did you use the treatment medicine, whether it was active drug or placebo, as prescribed every time you had sex or frequently during sex? And those people who said they were reported PrEP systematically or often were considered to be adherent. And then they looked at the intervals between study visits in which participants used fewer than 15 pills or 15 or fewer pills per month in order to get a sense of the intervals in which people were only infrequently having sex. The complicated thing that they then did was trying to figure out what interval someone got infected in. And so, because you'd want to know, did I use PrEP during this period of time when I got infected, and did it fail to work? So what they did was this complicated staging, and they looked back based on the different HIV test results and tried to estimate in which stage someone got infected, and only used those stages in which they anticipated that someone got infected when people met their criteria of fewer than 15 pills per month and reporting PrEP systematically or often. So there's some methodological issues with this analysis. So overall, they had 400 participants who had 431 person years of follow-up, and in this analysis, they had 269 of the 400 participants who met criteria in 134 person years of follow-up, so about a third of the total analysis. In this group, again, selected because they were having infrequent sexual exposures, there was a median number of pills taken per month of 9.5, with a median number of sex acts per month of 5. So still fairly frequent sex, but definitely less than the overall. The results, basically, this is the main slide for this analysis. And so you can see in the top row, in the placebo group, that the 130 so person years of follow-up were split pretty equally between the placebo and the active drug arm. But every single one of the infections who make criteria for these intervals occurred in the placebo arm, for an incidence rate of 9.3 per 100 person years and protection estimate of 100%, with a fairly wide range of 39 to 100% protection using the strategy, but pretty significant. And the conclusion from this project was that on-demand PrEP is an adequate alternative to daily PrEP for men who have sex with men but high risk but infrequent sexual intercourse. Fairly small number of person years being followed, but there are something like 30,000 people on PrEP using this strategy in France right now, and it is being used elsewhere in Europe. So something I think we're going to be talking about a lot more. Okay? I'm going to move on without making other sort of editorials about this to talk about HPTN 077, which was a study presented by Rafi Landowitz from UCLA, looking at the safety, tolerability, pharmacokinetics of long-acting injectable cabotegravir in low-risk HIV uninfected women and men. So phase 2 trial looking at safety and tolerability primarily. This was low-risk folks. Again, I just said the aim. So the design of this was a multi-site, double-blinded, randomized in a 3-to-1 ratio placebo-controlled study. And they enrolled 199, I don't know where the 200th person went, 199 HIV uninfected folks at low risk for HIV at multiple sites around the world. Their primary endpoint at week 41, and I'll show you a schematic, and the study is ongoing but will be completed soon. So this was a preliminary analysis. It's a complicated schematic, and the reason for this is that they initially did this, and cabotegravir is a novel strand transfer integrase inhibitor, that they initially did it, again, 3-to-1 ratio, but they were using cabotegravir at 800 milligrams with an injection every 12 weeks. And the Eclair study, my computer added the accent, I don't know whether the accent actually goes there, that the Eclair study suggested that pharmacokinetics were not significant with this dose of 800 milligrams of cabotegravir every 12 weeks. So there's a second cohort. The first cohort stopped enrollment, the second cohort started, and they changed the active regimen to 600 milligrams injected every 8 weeks. And what you can see is and the strategies were pretty much the same. In both of these groups, there was a 4-week oral phase lead-in of 30 milligrams and then injections. And injections to get to that 41-week endpoint depended on which strategy. So in the 12-week strategy, they got 3 injections at week 5, 17, 29, and then final outpoint at week 41. In the cohort 2, they received more frequent injections at week 5, 9, 17, 25, 33, again, to get them to week 41. And then there was a tail phase of follow-up. There's a lot of results from Rafi's talk, and I would encourage you to watch it if you are interested in looking at this. What I wanted to pull out was really the safety and tolerability bit about cabotegravir injections. And so this is a slide showing all of the grade 2 or grade 3 or 4, anything higher adverse events that were experienced by a large number of the study population, combined between cohort 1 and cohort 2, but divided between the active drug cabotegravir in the lighter color and placebo in the dark gray slashed. I can't see close enough to see what that is. And so what you can see is a fair number of AEs are reported, but many of them are reported both in the active arm and placebo. If any of you have done randomized trials, we know that headaches happen secondary to placebos quite a lot. But what's here in the red bars are the two that are significantly different between active drug and placebo. And the two were injection site pain, which was reported by 34% of the group in the active drug compared to only 2% in the placebo who are getting placebo injections, as well as headache, much more common in that active drug arm. There are several other sort of random assortment of adverse events that were reported, which I'm not going to show you. I'm going to show you there was one seroconversion. Again, this was a low risk group, so not expected to acquire HIV. So one seroconversion in the active arm that was detected at week 77, so the 48 weeks after the last injection. And in this participant, the cabotegravir levels were below the limit of quantification at weeks 53 and 77, and this person acquired wild-type virus. They measured levels because in many of these injectable and long-acting studies that drug levels can persist for extended periods of time, but this person did not have detectable drug levels. So in summary, long-acting cabotegravir was well tolerated, both at doses of 800 milligrams, which was given as 2 injections, as well as 600 milligram injections that was given as once, in HIV uninfected and low-risk men and women. Injection site reactions for long-acting cabotegravir are frequent but generally mild, but one participant did discontinue study medications because of an injection site reaction. And then what I didn't show you is that the targets for pharmacokinetics after this 4-week oral loading dose met their pre-specified PK targets, and there are phase 3 efficacy studies ongoing in high-risk individuals. And I added for you the name of the study and the link in clinicaltrials.gov if you are interested in following up on this. And then I just want to quickly tell you a little bit about a field that is very new to me, talking about the vaginal microbiome, and particularly as it relates to PrEP, because I think there's one, Sharon Hillier's absolutely fabulous speaker, but also I think as we start talking about topical PrEP, particularly for women, that this is going to be something you're going to be hearing about quite a lot more. So she included a lot of information, so her title is about impact of vaginal microbiota on genital tissue and plasma concentrations of dapivirine, but she presented a lot of this related data about tenofovir at CROI earlier this year, and so her slides include both for comparisons, and I thought it was valuable for you to see the comparisons between tenofovir and dapivirine. The tenofovir gel studies come from mostly Capriza. One in this work was done by Nikki Klatt here at the University of Washington. And the short story is that the vaginal microbiome impacts PrEP and impacts levels of tenofovir. So what Nikki Klatt showed based on the earlier results of the tenofovir gel was that this is efficacy of PrEP divided by whether or not people have a lactobacillus dominance, which is the normal vaginal flora, compared to other vaginal flora associated with bacterial vaginosis. And so divided into people who are lactobacillus dominant, efficacy of PrEP was estimated to be 61%. Overall, I believe the efficacy was 39% in this trial. So higher efficacy in women who were had normal vaginal flora. In contrast, if you look at the women who had non-lactobacillus dominant vaginal flora, so had BV, there was no impact of tenofovir gel on protection against HIV. And the question is, how is this working? What is the result of this? And so the slides that I'm showing you here are looking at cells cultured with tenofovir having bacteria either predominant in bacterial vaginosis BV, such as Gardnerella, versus cells and tenofovir cultured with lactobacillus predominating species. And so the short answer, actually, the nice red bar here is if you look at tenofovir levels in cells that are cultured with Gardnerella, that tenofovir levels are lower. This is cell culture. This is not in humans. And if you look here on the right at adenine being a marker of basically the breakdown of tenofovir as a nucleoside. I'm no expert in this. I apologize for my microbiology, my biochemistry a long time ago. So tenofovir as a nucleotide analog being converted to adenine, that in the cells that were Gardnerella, there was more conversion of tenofovir to adenine. So the thought with the dapivirine ring, dapivirine is a non-nucleoside reverse transcriptase inhibitor, that it would not be converted to the same degree by the bacteria. And so the objective and hypothesis of this presentation was to look at whether the vaginal microbiota associated with bacterial vaginosis impact dapivirine concentrations in the genital tract tissues and plasma following vaginal application, with the hypothesis that the microbiota associated with BV, so Gardnerella species, will not decrease genital tract tissues and plasma levels of dapivirine like it has been shown with tenofovir. So just briefly, these were 66 healthy, non-pregnant women from Pittsburgh, where Sharon is based, who were using effective contraception, who were asymptomatic, HIV negative, and had no other sexually transmitted diseases. The study design was these women had tenofovir or dapivirine film or gel applied in clinic, and they were collecting vaginal swabs to look at their bacterial species. They were then sent home with the film or the gel and asked to apply that daily. She was asked why they weren't given the ring, and her response was the estimates of plasma and other tissue levels from the ring were equivalent to film or gel, and presumably it was just easier to do it using the film or gel. But that was one question that was raised during the conference. At day 7, they came back to the study and they collected plasma, cervical vaginal lavage, and vaginal fluid for drug levels. There was actually a 7th dose of the film or gel applied in the clinic, waited 2 hours, and then plasma levels were collected as well as cervical biopsies to look at tissue levels, with the idea that many of these topical microbicides actually get plasma levels, and that perhaps is some degree of how they are protecting. So I gave you a selection in the next 3 slides of her results, and there is out here your Nugent score is a combination score for bacterial vaginosis. The lower Nugent scores are normal cells. The higher Nugent scores are bacterial vaginosis. You can see these lovely pictures down at the bottom of each figure for you to clear it. And in tenofovir, they saw what they had seen in previous tenofovir studies, which is that tenofovir levels in women who had lower Nugent scores, so normal vaginal flora, were higher than tenofovir levels, whereas there was no difference in dapivirine levels depending on whether you had high or low Nugent score, as predicted. The next is looking at cervical tissues compared to concentrations of Gardnerella vaginalis. Gardnerella, again, being associated with bacterial vaginosis, so the higher levels of Gardnerella associated with more pronounced BV. And again, there's a quadratic relationship, but you can still see that the more Gardnerella you had, the lower levels of tenofovir you had, but no impact on dapivirine. And then finally, looking at lactobacilli of various species, genus, that as you had increasing amounts of lactobacillus, your tenofovir level went up, and there's not a significant change in dapivirine. So it's a complicated summary, but in contrast to tenofovir, as expected, genital and plasma concentrations of dapivirine were not decreased by bacteria associated with BV. She suggested that the levels of dapivirine following vaginal application should not be impacted by those microbiota, and that it was supportive of the ASPIRE study results. That was a study of the dapivirine ring that said that even though 40% of the women had BV at baseline, there was no difference in efficacy of the dapivirine ring compared to those women who did or did not have bacterial vaginosis. And then just a new focus of work for need for prevention products and understanding how your prevention products may work, particularly topical prevention products in women and women with BV or vaginal dysbiosis. I just very quickly want to tell you, and this may not be all of the medications, but I just wanted to sort of summarize where we are for alternatives for Truvada. We've talked before about Maraviroc, which was published by Trip Gulick in the male cohort last year, and the female cohort is in publication. The Descovy trial, which I think everyone is really interested in, which is the combination pill of tenofovir alafenamide and emtricitabine, is ongoing, expected results in a few years. And then in addition to the cabotegravir studies that we presented here, there's a dolutegravir implant that was presented about implants in mice, including removable implants, as well as long-acting rilpivirine, which you'll hear a little bit more about probably from Brian about treatment. And then finally, I think one of the dapivirine ring there's now studies looking at safety and efficacy in U.S. adolescents that was presented as a poster here. The original paper is by Jared Beaton from New England Journal of Medicine last year, showing efficacy in subpopulations of women in Africa. So that was my last slide, and just questions.